what is, as we know from the Commission's work, a massive inequity in access to diagnostic testing. And we've been working to reach a significant percentage of the world's population who currently have little or no access to diagnostic tests. So we warmly welcome this strong statement from the esteemed Lancet Commission, which sets out a very clear agenda on the role of diagnostics in universal healthcare. It's really only been very recently that the value of testing and diagnostics has come to the forefront and started to be recognized widely for its importance in healthcare. First, the Essential Diagnostics List was published in May of 2018, which was a notable event and also notable for the fact that it was 40 years after the first Essential Medicines List. Not long after that, this Lancet Commission was set up with a very large remit and a tremendous amount of work on its plate to understand the value of diagnostics and the gaps in equity and access to diagnostics across a number of disease areas. And then COVID hit. And as we all know, the gaps that the Commission had been working to identify and articulate and quantify were magnified tremendously and laid bare for nearly everyone across the world to see and understand. And moreover, everyone overnight became an expert on testing and the critical importance of testing. Political leaders, pundits, and even the average citizen trying to navigate their own healthcare very suddenly had strong and clear opinions on how critically important it was to access reliable testing. So in that sense, the Commission's work and its report today could not be more timely. The entire world, quite literally, has been sensitized to the critical importance of reliable and accessible testing in a way that tens of millions of undiagnosed cases of tuberculosis or hypertension could never bring to everyone's daily news feeds. And so the Commission's recommendations really form an essential blueprint that can help us address the diagnostics gaps that are weakening health systems worldwide and really putting people's lives at risk every single day. So what's important today is that we listen to the Lancet Commission, understand its findings and its recommendations. What's important tomorrow is that the diagnostics and global health community step up and gratefully accept the baton from the Lancet Commission. At FIND and with our many global partners in the Global Alliance for Diagnostics, we stand ready to take action, to operationalize these recommendations, and honestly, to be held accountable for making progress in closing the massive gap in equity in testing. So we're very privileged to be co-hosting this milestone event today with the Lancet, and it's my great honor to hand over the microphone to Richard Horton, who is the editor-in-chief of the Lancet, to kick off today's event. Richard?
Thanks, Bill. Welcome, everybody. Thank you so much for joining this very special moment. It's certainly true that diagnostics are the Cinderella of global health. They receive far too little attention, and they absolutely deserve to receive more. The primary goal of this commission is simply to put diagnostics on an equal footing with the attention we give to medicines and vaccines. And we need to be honest here. I think that the neglect that we've seen paid to diagnostics has sometimes been our own fault in the health community. We ourselves have underestimated and underappreciated the importance of diagnostics in our practice. Let me give you two examples. At the beginning of the COVID-19 pandemic, one of the deputy chief medical officers in the United Kingdom argued at a government press conference that testing for SARS-CoV-2 was inappropriate in the United Kingdom, not needed at all. An absolutely astonishing statement from a government scientist. 20 years ago, my second example, I remember sitting next to a senior health advisor at a global health agency, I won't name which one, who argued that rolling out HIV testing in sub-Saharan Africa was unnecessary and logistically impossible, as was antiretroviral treatment. The best that one could hope for, he argued, was to prevent the next generation of people in sub-Saharan Africa from acquiring HIV. Not merely an astonishing statement, but a genocidal statement. So the findings of this commission underline the neglected attention paid to diagnostic in almost all spheres of global health. And the commission is an urgent piece of work that deserves not only to be read widely, but to be acted on rapidly. For ourselves at the Lancet, publication of this report is the beginning, not the end, the beginning of putting the evidence set out in the commission to serious work. The scope is remarkably broad, covering infrastructure, workforce, quality, safety, financing, governance, and policy. And the pandemic actually provides a once-in-a-generation opportunity for a complete reset in our understanding, appreciation, and attention to diagnostics. So let's seize this opportunity. The commission could not have been delivered at all by ourselves or the commissioners without the tremendous efforts of a group of partners who help fund and support the work of the commission over the past couple of years. And I do want to name the partners because they've been essential. So a huge thank you to the Gates Foundation, welcome, the Brochure Foundation, the Canadian Institutes for Health Research, King's College London, the International Academy of Pathology, the World Pathology Foundation, the African Strategies for Advancing Pathology, and the Universities of Oxford, Vermont, Waterloo, and Harvard. Thanks to FIND for this launch. Thanks to my colleague, Sabina Kleiner, our editor who led the project for the Lancet, and of course, and especially our chair, Ken Fleming, and deputy chairs, Sue Horton, no relation, Mike Wilson, and the wonderful commissioners. So let me hand over straight away to Sue and let's get this show on the road. Thank you.
Welcome, thanks for joining us today. I'm going to give you the punchline right now, the key messages of the commission. Next slide, please. So in the first couple of slides, I'm going to go over the 7 key messages and then sort of 1 slide per message to amplify. So the headline is that nearly half of the global population has little to no access to diagnostics. And that's a scandal because of the importance of diagnostics. And as was said before, diagnostics are the Cinderella, the neglected. And one illustration of that is that in the Sustainable Development Goals, medicines are mentioned for health. The medicines are mentioned 4 times, but vaccines are mentioned 3 times, but no mention is made of diagnostics. Diagnostics also have equity issues. The people who do not have access to diagnostics are the poorest, the most remote, the rural population, and the people who have less education. And it exacerbates the inequality in health if they cannot get access to treatment by being diagnosed. And now is the time to do something. Everybody understands, due to the COVID-19 pandemic, how important testing is. And probably most of us have been tested for COVID, and we need to be tested for other conditions, not just that. Next slide, please. So the good news is that technology has changed rapidly and can help to transform access and to make it more equitable and more available. And the good news is that by improving access to diagnostics, we can save a significant number of lives each year globally. And this is a low estimate because we focused on 6 conditions only. Lastly, I'm an economist, so I did work to show that each dollar invested in diagnostics can yield economic benefits. Next slide, please. So here's an example of access. So access here refers to not only diagnostics being available in health centers, but also people having access, i.e. within 2 hours of their home. That was the definition that we used. And we looked at a very, very basic set of about 8 diagnostics at the primary healthcare level. Here's the results for Malawi. So it's the availability and also using GIS data, how many people have access. So blue is good in this chart and red is bad. You can see we've had success in getting HIV diagnostics broadly disseminated, although even in Malawi, which has high prevalence of HIV, there are regions where it's still not very accessible. But the picture is really different once you get to many other diagnostics, particularly for the non-communicable diseases, and glucose testing so important for cardiovascular health. You can see you essentially only get access to that if you happen to live near one of the 4 major central hospitals in Malawi. Next slide, please. Why are diagnostics essential? Here's the role that they play in universal health coverage. So availability of diagnostics makes treatment more appropriate, and by avoiding excess use of antibiotics, helps to reduce antimicrobial resistance and hence improve health. But equally, universal health coverage is aimed at reducing impoverishment due to ill health. And although diagnostics cost additional money, they reduce the cost of providing treatments that will not benefit the patient. And also they improve productivity and income by reducing mortality and morbidity, and hence reduce impoverishment. And that it's also a public health issue to have diagnostics. Next slide. So all too often, governments focus on very visible improvements in diagnostics in the central hospitals and the teaching hospitals. And it's less easy to see the importance of improving access to very, very basic technology, strip tests, for example, at the primary healthcare level. But if people cannot access diagnostics at primary healthcare, there's no chance that they can, with severe conditions, reach those central hospitals with their CT scans and their MRIs. Next slide. And it's not fun being tested for COVID, as everyone here will attest, but it's super important, and universal health coverage cannot be achieved if we do not improve access to diagnostics. Next slide. Here are a slide summarizing some of the benefits that improved technology can provide. So point of care testing can help to revolutionize access to diagnostics. Digitalization, which allows teleradiology, telepathology, for example, is also vital in improving access. Democratization, where people can test themselves or even provide samples and collect the samples themselves and send them in to be tested, improves access, and especially for diseases where there is stigmatization. And artificial intelligence can revolutionize access to care. Next slide. Diagnostics is the biggest gap in the cascade of care. These are data for low and middle income countries. The only exception is hepatitis B, where the only country with good data was for Australia. So the blue bars represent everybody in the population who has a condition, and you can see the huge drop off before you get to the orange bar, which is the people who are diagnosed. And that's larger than the treatment gap, which is the gap between the orange and the gray bars. And our calculations suggest that 1.1 million lives can be saved globally each year by improving diagnosis in the low and middle income countries. Next slide, please. And I'm an economist, and what this chart shows is that $1 invested in diagnostics yields multiple benefits. The highest benefits are in the infectious disease, where you can get $24 for each dollar that's spent. But across these 6 important conditions, the returns range from 1.5 to 24 for each dollar that's invested. Next slide, please. Now, I'm going to turn this over to Mike, who's going to tell you how to make change.
Thank you, Sue, and thanks to everyone who's joined us on this launch today. Next slide, please. So as Sue had mentioned, there are a number of things that we have arrived at as part of our commission for improving the access to diagnostics globally. And the first of these is the creation of a national essential diagnostic list. As was mentioned earlier, the WHO launched their essential diagnostics list in 2018 and have been updating it since then. But to date, only one country has really taken the next step, and that was to create their own national list. We realize that this is a big hurdle for people to do this. And so we have provided a template for countries to identify the essential tests for 3 levels of health systems, prioritizing the conditions for testing based on the global burden of diseases. And then we model whether the conditions were triaged but not treated, treated in an uncomplicated form, or treated with complications. Next slide, please. And a result of our analysis is shown in the diagram at the right. At the bottom, in the primary health center level, a relatively small number of tests are needed, such as point of care ultrasound, laboratory tests, and microscopy. But then as one moves up to the first level hospital, the menu of diagnostics that are needed expands to include more diagnostic imaging, as well as more sophisticated and more high throughput laboratory tests. And then obviously, as one moves up to the level of a referral hospital, more specialized testing in all areas is needed. And this is a part of an integrated tiered network concept where both specimens and patients can move between tiers to get testing that's appropriate for their level of care. Next slide, please. Infrastructure is a clear barrier in many parts of the world, and I think most of us who have worked in global health for years know what those infrastructure problems are, both physical as well as operational. And rather than take the approach of looking at how to fix specific infrastructure issues, we took a broader view and really 2 key conclusions. One was that systemic solutions are needed. We know at this point that piecemeal approaches to try to fix infrastructure simply haven't worked. And the other one is affordability. And it's going to take financing to fix a number of the problems with infrastructure. And I'll have a slide on that in a few minutes. But the essence of fixing infrastructure globally for diagnostics really is going to be obtaining adequate resources to do so. Next slide, please. Workforce capacity is obviously a key issue. We need to have workers to do the diagnostic work around the world. And based on modeling that we've done, the global shortfall in diagnostics workers by 2030 are going to be between 840,000 and just over 1 million. Slightly more than half of these are in pathology and laboratory medicine, and slightly less than half in medical imaging. And while we realize that it's unrealistic for LMICs to increase their workforce capacity to these benchmark levels, there will have to be some absolute increase in the number of workers around the world. But to mitigate this gap, we simply need new approaches to work. We need new ways to get diagnostics into the field, into the hospitals, and base it around team-based work, task sharing, and a number of other approaches. There clearly need to be changes in educational and training programs, both in the scope as well as the duration. And a key factor going forward is to improve continuing professional development, particularly, as Sue has previously mentioned, with the rapid changes in information technology. We are going to have ways to keep the workforce up to date going forward. Next slide, please. Quality and safety are obviously key issues in diagnostic. One of the things that pathology and laboratory medicine really needs around the world are better regulatory frameworks to create 2 things. One are programs for accreditation, but also for external quality assessment. For diagnostic imaging, the needs are slightly different. What is needed there are regular and systemic review programs for the processes and procedures, but particular safety standards in places that aren't used to using diagnostic imaging equipment. And then again, we really need programs to help ensure professional certification, competency, and again, especially continuing professional development. Next slide, please. In the area of policy and governance and financing, again, countries need to have national diagnostic strategic plans. Part of these are the national essential diagnostic lists that I mentioned previously. But these need to be aligned and tied into the integrated tiered diagnostic systems that were part of our framework. And then again, these national strategic plans need to create regulatory frameworks. We realize that there is a risk if there are too many national systems that are different. So to mitigate that potential risk, national systems could be aligned with to things such as food pre-qualification or regional harmonization programs, because we realize that already the number of unique national regulatory systems does create some barriers to moving access into, particularly into lower and middle income countries. Next slide, please. We did want to call out in the commission the dire strait of persons living around the world in fragile and conflict states. Nearly 1/3 of the world's population lives in these settings. There are a number of active conflicts around the world, and up to 70 million persons have already been displaced. And we realize that just as with the healthcare system as a whole, bringing diagnostics into these unstable settings is going to require innovation in technology and processes and everything that we've talked about in terms of achieving change. But this special group of individuals really needs to have a special and unique set of access to diagnostics. Next slide, please. Global health security is another issue that we call out on the report. In addition to COVID-19, which we've already discussed earlier, there are other infectious disease outbreaks that are ongoing around the world. And all of these do require access to diagnostics for countries and for the planet to address carefully. But we want to avoid siloed development of diagnostics for specific diseases, because the risk of that is just that we won't be able to scale this up. And so we've learned one thing from the COVID-19 pandemic is where we had pre-existing systems, diagnostic systems and healthcare systems, and particularly where the diagnostics were more flexible, we were able to rapidly scale up diagnostics to address the COVID-19 pandemic. And we think there's a very valuable lesson to be learned there. Next slide, please. And then in financing, as I mentioned earlier, particularly to address issues such as workforce and infrastructure, we really need new sources of financing to expand access to diagnostics. And we realize that in most countries, the public sector will address most of the financing with some complementary financing from external sources. And we present a number of ways to do this. Some are very basic, simple things such as strengthening tax collection and judicious increases in taxes. But we also think there are innovative financing models as well, such as development impact bonds that have already been shown to be effective in some settings. So we provide some ideas for countries and ways to increase their financing to help address the shortfall in diagnostics. And can I have the next slide, please? All right, thank you. And now we'll move on to Ken, I believe.
Actually, it's I'm handing over to Patricia, Patty Garcia.
Yeah, hi, thank you. And thank you very much. I have been one of the commissioners, and I really hope that the message about the importance of diagnostics gets through in all the languages for all the countries to really assure the access globally. I come from Latin America, and I need to make this comment because I think it's important. In English, you have a clear difference between diagnosis, which is this process of recognizing an injury, a condition, or a disease, mainly from the signs and symptoms of the individual, and diagnostics, which are the means, which means the tests and exams that are used to ascertain the diagnosis. The word for diagnosis in Spanish is diagnóstico, and we do not have a specific word for diagnostics. We also translate it into diagnóstico. So we really need to be sure that the message is clear. Again, in all the languages, we need the means to ascertain better diagnosis, which is our goal. We're talking about diagnostic tests and diagnostic imaging. That is what we need all around the world. And one of the things that came out after all these discussions within the Commission is that there are responsibilities at the national level and at the global level that need to be undertaken. The first one is that there is a need to create a national diagnostics strategy. This goes beyond the usual concept of a plan, but is not suggesting to create a new program like a TB program or an HIV program. This is a strategy that should be diagonal to all the system, and that should go through all the levels up. And there is no intention of creating or exacerbating or any disconnection between diagnostics and health services. We need to be sure that the tests for key conditions are available at all primary care centers, which are those centers that are closer to people. And technology could allow us to do that. We have been talking about point-of-care tests. We have been talking about democratization of tests with the availability of self-testing and self-sampling. And these are key issues that need to be discussed within countries and included. We need to invest in workforce expansion and upskilling because we need to develop the health workforce that can work effectively within the structures that we have. We need to talk about competencies, but we need to talk about task shifting and task sharing. That are two words that are very difficult to translate into Spanish too. And we need to address those issues. We need to commit to regulatory frameworks for medical devices and also for accreditation. We need to assure safety and quality, but although regulations are needed, it is critical not to put unnecessary barriers in place. It is not appropriate, for example, to have the same type of regulations to diagnostics as to medicines, considering that diagnostics are very different from medications. We need simplicity. We need to think about harmonization and considering issues like a pre-qual to simplify the processes within countries. And finally, and this is very critical because unless we have the money, we're not going to be able to roll out all this effort. We need new financing strategies, but that has to go with more money and also to be more efficient. For example, in procurement, in the use of resources, issues like pool procurement systems, equipment standardization, and fostering national and regional capacity for manufacturing. That is something that we have seen critical during the COVID time. So I think it's critical to think about these issues. And as it has been said before, countries at the national level need to think about other strategies to increase financing that could be new. One of the things that has been discussed also are these kind of like the sin taxes, or these taxes that go into those products that are not that good for health, like tobacco or alcohol or sugar beverages, whatever. This is the time that countries need to take the responsibility and think about the package, not only the medications, it's the package of what diagnostic I need, not only the medication, to really assure that we can reach universal health coverage and better health for all. Thank you. And I think now it's John.
Yeah, thank you. Thank you so much. But I think I'll just speak off my notes and not necessarily use slides. I think there's some, this to me is a really a great day because there's a need, as Bill said earlier, to think of what do we do with these recommendations and translate them into action. And before I go into a few slides and then share my reflection, I just really want to say how much privilege I felt to be associated with this, the Lancet Commission on Lab. And I remember a call I had with Sue Ilton when this idea was being conceived, and she called me. I was in China, actually, and wondered if I could make recommendations on people in Africa where they could talk to. And later on was kind enough to invite me to join this very important group. And to me, it was remarkable because spending my many years in public health in the lab area, it gave me joy that the Lancet finally was taking on this. We had over the years, of course, written so much about laboratory negligence, which a word that some ministers don't like. They think if you say you neglect you neglect lab, it means it's a willful act, but we don't know a better word for that. So let me share some personal reflections on the severe need for diagnostics and how diagnostics is actually neglected. At some point, if you all recall, it was a bad word to use the word viral load in HIV management. I mean, and arguments you get at that time was that testing doesn't cure people. And viral load, for example, was too expensive. You were irresponsible. I mean, we were literally characterized like being irresponsible. And then our thinking shifted. And we now, all of us started talking about the 1990s, the importance of viral load. So you leave there at that point, you leave it there. You said, as a continent of 1.2 billion people, we do conduct about 100 million HIV tests a year. And yet there's absolutely no country in Africa or a factory that produces a simple rapid HIV test on the continent. And we have been doing this, that is living with HIV for about 40 years. And why is that so? So I think that there's following recommendations at the international level speaks to the improved affordability of diagnostics. And I started with the viral load because it has HIV, because it has been a formidable challenge and continue to be so. We just have lived with are currently living with the COVID-19 testing, where the people that perhaps fought the 1918 pandemic will be envious of us, that this generation within a few weeks were able to develop a diagnostic test for COVID, but it was still not widely accessible. As a continent of 1.2 billion people, we have already conducted less than 80 million COVID tests. So again, we need increase or improve affordability of diagnostic tests. Development and use of technologies in ways that benefit everybody is, again, exactly what I use those two examples, i.e. the viral load example for HIV, the general HIV test, and the COVID to demonstrate. We need to address these limits, these needs at population level, and of course, be adaptive in our thinking with respect to what kind of test do we need, that kind of point of care test versus tests that really require laboratories, and also make sure that people living in conflict areas also have access to tests. I mean, testing should not be limited only to those who are privileged. I think that is so important, the vulnerability. This COVID pandemic has taught us how connected we are as a people, how vulnerable we are also as people, and how and further expose the inequities that we knew existed, but have not actually been brought to the surface the way it is there. The ninth recommendation is increase recognition and funding for diagnostics. None of what we are putting forward will ever happen without increased funding for diagnostics. And again, Richard has mentioned this, is always the least area that receives attention in funding. And lastly, establishing an international diagnostic alliance to support and monitor all of the above. Now, in 2018, September 2018, the ASLM, the African Society for Lab Medicine, which has done an incredible amount of work to highlight the importance of lab medicine on the continent, worked with Africa CDC to launch what we call the African Collaborative to Advance Diagnostics. At that time, there was no COVID, but it was amazing that forward thinking, driven by an African institution, ASLM, or institutions, ASLM and Africa CDC were at the fore of that. Those kind of regional initiatives will be very important if we have to translate the recommendations from this report into action. Yeah, so I think the next, please. Can we move to the next slide, please?
I think the next slide, John, might be the next panel.
Yeah, so that's, just wanted to thank I mean, again, the commission for including me as part of this conversation, Ken. So over to you.
Okay, thanks very much, John. Good morning, good afternoon, good evening, ladies and gents. I'm Ken Fleming. I'm actually the chair of the Lancet Commission, and I'm going to be moderating this second half of the session. First half, you've heard about the results of the commission and some of our findings. In the second half, we've got a panel of very distinguished experts. We're going to ask them some questions initially to start. And then we're going to have an open question and answer center session. If people want to ask a question, could you please use at the bottom of the Zoom, there's a Q&A option down in the right-hand corner, not so much the chat, but the question asked. And if you get any questions, please put them in there. We're now showing a slide of our distinguished guests, panelists. Let me just introduce them. I'll do this alphabetically. First of all, we have Dr. Pascal Ondoa, who's the Director of Sciences and New Initiatives at the African Society of Lab Medicine that John has just mentioned. She's based in Ethiopia, a medical degree, a PhD in virology, and she's also affiliated with the Amsterdam Institute of Global Health and Development as an assistant professor. Second, we're privileged to have Dr. Vinod Paul, who leads the Health, Nutrition and Human Resources Development section at the NITI Aayog, which is probably the premier policy unit for the government of India in fostering sustainable development in India. He's a pediatrician and physician scientist by background and worked previously at the All Indian Institute of Medical Science. Next, we're again very lucky with Dr. Peter Sands, who's the Executive Director of Global Fund, which needs no introduction. He's an expert in international financing and global health, which has been mentioned many times, particularly for infectious disease. And lastly, we're privileged to have Dr. Samia Swaminathan, who's a pediatrician and clinical scientist known for her work on TB, but many of us know as the chief scientist at the World Health Organization. So I'm just going to ask their panel a couple of questions to start things rolling. And I think I'll start with Dr. Peter Sands. Peter, if I can ask you, with lots of messages and recommendations in the commission, of these, which do you pick out as perhaps the most important message and recommendation? And would you have some advice about how best to implement that? Clearly, implementation is a key issue.
Thanks, Kenneth. And to start with, I should make clear I'm not a doctor. I'm an economist by background. I would pick recommendation, I think it's 8, which is around the recognition and financing of diagnostics, because to my mind, we still have a big job on our hands in convincing people of the importance of diagnostics. I mean, if I take COVID-19, for example, where we, the Global Fund, have been the primary provider of diagnostics to low and middle income countries. We've deployed about $850 million worth of diagnostics. Actually, the inequity in vaccines is exceeded by the inequities in diagnostics. The testing rates in low-income countries are minuscule relative to what we are seeing in wealthier places. And I think part of this is that we haven't yet managed to articulate clearly enough what diagnostics do in a way that politicians can grab and turn into a communication for their publics. Vaccines, the message is very simple. It stops people, they stop people getting infected. Treatments, the message is almost equally simple. If somebody does get infected, you save their life, you help them get better. Actually, the problem with diagnostics is that they serve multiple purposes. And those multiple purposes actually kind of confuse and dilute the message. So test and treat. Diagnostics are the gateway to getting treatment. You don't get treatment until you've been proven to have the disease. And for diseases like TB, that is the big obstacle. Diagnostics are also crucial as the underpinning to public health measures. If you want people to quarantine or isolate, if you want to change behaviors so as to reduce transmission, you need diagnostics in the community. Diagnostics are crucial for any form of disease surveillance, understanding the problem we are dealing with. How much is there in the population? Do we have variants? All that kind of stuff. And diagnostics are also critical to actually enabling societies to live through and with infectious disease outbreaks, as we've seen with COVID. So enabling schools to open, key businesses to function, regular testing becomes part of the way that that works. And it's almost because of the multiplicity of roles that tests play that we found it, I think, harder to articulate their crucial role. And it also doesn't help that within the global health community, people tend to focus on one more than another of these and don't necessarily like or support the others. And so there's a sort of, the global health security community is very focused on the surveillance aspect. And a lot of the sort of more clinically oriented people are very focused on the test and treat aspect. The bit I think has been disappointingly under-supported in the COVID response has frankly been the deployment of community-based testing to support public health measures. What we have learned from many years of other infectious diseases such as HIV and TB is if you give communities the tools to protect themselves, they will do sensible things. What we should be doing now, particularly in those communities that have been hit hard by Delta and have low vaccination levels, but frankly, even those with pretty high vaccination levels, we should be flooding them with cheap antigen RDTs. Because that's the key to enabling communities to protect themselves. So I think we have a big task on our hands to get greater recognition and greater clarity on the role, the crucial roles that testing provides within a health response, and translating that into funding, because we're clearly not at that yet, still not at that yet in the COVID response. I'd also just quickly say one thing that has really struck me about the disruption to HIV, TB, and malaria services as a result of the COVID pandemic has been the thing that has suffered most, has been the testing. It's the first thing to go. So HIV testing fell by 22% in 2020, and TB, the test and treat aspect of it, fell by 18%. That's 1 million less people who got tested and put on treatment for TB, and that will result, sadly, tragically, will result in hundreds of thousands more deaths. So I very much welcome the Commission's report and recommendations, and we still have a task on our hands collectively to drive diagnostics up the agenda in terms of visibility and funding. Thank you.
Okay, many thanks, Peter. Actually, it's an interesting observation that it's getting the message out about the centrality is the key thing. Hey, Paul, have you got thoughts on all the recommendations which we've made or the messages which come out, which you think might be the most important, or do you agree with what has just been said? Dr. Paul, can you hear me? Oh, well, we might be having a little bit of trouble. Pascal, would you like to comment on that? Have you got a feeling about our recommendations and messages about which is the most important?
Yeah, thank you, Ken. I think that the 10 recommendations are all very strong, but if I have to pick one in terms of hierarchy of importance, I think that the second recommendation for me is the one that answers the problem that is highlighted by the Commission, which is that half of the population in low and middle income countries do not have access to diagnostic, even more so in the community. So focusing on increasing availability and access to diagnostic in primary healthcare setting does answer this point. And I think in a way, the 9 other recommendations are in support of this central one, including the EDL, which is a mean to that end. So I think that that's very important. That recommendation cannot be negotiated in a way. And all the others, we can always tweak them to make them more relevant, more implementable. And if I would take the example of forming a global alliance, which is really great. I think Dr. Nkengasong alluded to the possibility to use some of the existing organizations like the AFCAD that he just mentioned. And also we can find ways to increase the representative for low and middle income countries in this sort of alliance, increase the numbers of low and middle income countries that are there, and also their power in the decision making. I think that's an important point. If we look at the recommendation number 7, which is about fostering how these diagnostics can be more usable on the ground, I think that there are also some ways to tweak it. And for example, recommend that there are more demonstration studies when diagnostics, new technology are being promoted, that we have more understanding of what are the determinants that make them a success in community settings, and that before we start to heavily advocate for them. So I think that there are ways to improve all the other recommendations, but that one, the number 2, I think for me is central. So if I would add something to make this recommendation even more powerful, I think that there are some indicators of access and availability in that one. I would add, if possible, some indicators that can demonstrate that, yes, the results of those diagnostic tests are indeed used for patient management and for public health action. And that's really to acknowledge the fact that, yes, diagnostic is central, but it is also in support of health. So it's central, but it's also in a supporting role, and health is the endpoint of that role. So these are my highlights.
Great, many thanks, Pascal. Really interesting, the point about primary care. So Maya, Dr. Swaminathan, do you have any thoughts from the World Health Organization's perspective about these recommendations and messages that you would pick out as a particular one that perhaps WHO should take particular cognizance of?
Thank you very much, Ken. First of all, congratulations to the commissioners for this report that the WHO very much supports. We've been saying for some time now that diagnostics is an integral part of universal health coverage, but as other speakers have said, this is not always very obvious or explicit to policymakers and to those who are doing the economic investments into health. Now, the WHO is obviously committed to universal health coverage. It's one of our key goals and pillars, the 3 billion targets, for example, having 1 billion more people achieving UHC. And it's clear now from the COVID pandemic, from the remarks that Peter made, that you can neither have universal health coverage, nor can you have pandemic preparedness or fight against communicable diseases without diagnostics. From my own experience, I was head of the Indian Council of Medical Research, and we set about trying to implement hypertension treatment through our primary healthcare network. And something as simple as a sphygmomanometer was not available in the majority of centers. So if you cannot detect hypertension, the next step of having the drugs, and then having the manpower and having follow-up is not going to be possible. So I think it's really important that the list of essential, and I'm so happy that the essential diagnostics list was mentioned. The WHO started producing essentials medicines list, I think in 1977. And it was in 2018 that WHO produced the first list of essential diagnostics. It is a very much aligned with the approach of the Commission. It's a tiered approach, point of care diagnostics at the PHC level. I agree that that's critical. And then diagnostic tests that you would have at secondary and tertiary care levels. We have something like 175 diagnostics, and we also have a separate list of medical devices, which has about 1,500 medical devices. So these lists are quite useful. They're now available on electronic platforms. They're useful for countries to look at because they have the essential requirements for a particular device, and they also have some tips on procurement. In terms of choosing one of the recommendations as the most critical, they're all so interlinked, so you need the infrastructure, you need the financing, you need obviously the tests themselves, and then you need the workforce. But I would think that all of this can happen only if the planners, the policymakers who are actually making the plan for delivery of health services consider and include diagnostics as an essential part of their proposal. And I think many countries today are going to be re-looking at their health systems to see where they went wrong, where they did better, where the gaps were. This is the time to really have that analytical approach and look at strengthening diagnostics. I know many countries are doing that now. When the pandemic started, for example, on the African continent, there were only 2 labs that could do the RT-PCR for COVID. This is, in January when we had the PCR protocols. And so one of the first things we did working with Africa CDC and with our WHO Africa office was to ensure that every country had at least 1 lab that became the referral lab for COVID-19. And then later on, and rapid tests and others became more available. But that was the state of affairs. And I think the pandemic has exposed the huge gap in diagnostics. So I would also go with Pascal to say that, I would really prioritize diagnostics at the primary healthcare level, but then I think all of the recommendations are important and they're interconnected and very much aligned with WHO's views.
Thanks very much, Soumya. Could I just follow up and change track slightly actually on that? Because one of our recommendations is going back to this issue about getting the message out. One of our recommendations is the World Health Alliance resolution about the critical importance of diagnostics. How best do we do that? Because it seems to me that if we can get that done, then as a sort of key milestone, it would be a really important way forward. From the WHO point of view, can you discuss how that best could be done?
Yes, thank you. So a World Health Assembly resolution obviously brings a lot of attention onto a particular topic, and it stimulates debate amongst the member states, and then it results in some commitments and in the form of a resolution, and it also then results in follow-up action. So normally there's a resolution, then the Secretariat has to commit to coming back to the Assembly every couple of years with a follow-up. And so while we've had many resolutions, on different topics, all of which implicitly recognize, like the resolution on non-communicable diseases, the resolution on TB, the resolution on HIV, they include diagnostics, but a separate resolution on diagnostics, maybe this is the right time to do that. And the way it would be done is that resolutions are brought forward by member states. So one or more countries would discuss and propose a resolution. It goes to our governing bodies. It's then tabled at the executive board. The executive board then discusses whether it's a priority and then passes it on to the Assembly. Then there's a period of negotiations around the wording of the resolution and what it should contain. And then finally it goes to the Assembly and it gets passed. It takes over a year to do that. But the results can be quite impactful because they bring it up at a very high level, at the level of the health ministers, and countries then need to have some accountability for acting on that.
Okay, thanks. That's really useful. Again, changing track slightly. Pascal, can I go back to you and just ask about, obviously, infectious disease is, if you like, diminishing in importance in low and middle income countries, with non-communicable diseases increasing. What about the diagnostics for those? Because a lot of the diagnostics we've been talking about have been about infectious disease. What about those ones for the NCDs? How do you see this developing?
I think it's a very important development to see that it's not that it's a good thing that non-communicable diseases increase also in low and middle income countries, but it comes with very interesting potential implications. So the first one is that so we have non-communicable disease. What are we talking about? We are talking about cancers. We are talking about disorders like digestive disorders or intoxications or cardiovascular diseases. So all of these constitute a very large basket of different diseases. So it means that in addition to now switch the attention more to bringing the diagnostic closer to people in the community, we also have to broaden our attention and also look at non-communicable diseases that are a different type of health issues. So it means that the revolution, if there is one, has to be at several levels. So bringing the test to the communities and then look at non-communicable diseases. And what is important is that, so there are various types of non-communicable diseases. So there will have to be a sort of process to select what are the ones that are associated with a larger burden of disease, and hence, how do you build the investment case for those diagnostics that will produce the best, the most impact? So that's an interesting question in itself. And it requires that we collect more and more epidemiological data that are locally relevant so that we can answer that question. So that's very important. Now, in order to control non-communicable diseases like cardiovascular diseases, diabetes, I think that the screening and prevention is very important, and it's not always the case for infectious diseases. And that means that having large screening programs, and reaching out to maybe elderly people or adult male that are traditionally difficult to reach out, it means that we will have to develop more innovative ways to reach out to people, to diagnose them and to screen them. So that's interesting. That gives a lot of value to, for example, self-testing for people to be diagnosed or screened. So I think it's very new, and it's another way to see things. And then, of course, you have all these non-communicable diseases like the cancer, which might require very sophisticated tests. So it's also a revolution at reference level in very sophisticated laboratory that would need then to have molecular testing, functional assays that are not, doable at community level, and that should reinforce the network capacity, the tier network function of diagnostic. So I think that it will strengthen also these function. And now finally, something that might happen is that, because we know that a lot of non-communicable diseases are linked to the lifestyles and to the socioeconomical status of the population, there might be a more visible link between the value of diagnostics and what the people perceive as being important, because then it would be directly linked to social intervention, public health intervention, because of those non-communicable diseases. And I think it can really put diagnostic in another place, which is more visible and valuable by the public.
Okay, thanks, Pascal. That's interesting. Good. One of the questions that's come in is about why did the Commission consider both imaging and pathology and lab medicine together? Why both of those? Bill, I think you've got a particular view on that. Could you respond to that question?
Sure, I'm happy to. I mean, I can't speak to why the Commission took it up directly, but I'm very glad they did, because it's been a critical gap in our approach to diagnostics in LMICs, and frankly at FIND, probably one of our biggest omissions over the years is to de-link testing based on bodily fluid sampling, blood testing, and sputum testing from diagnostic imaging. So I think the approach that the commission recommended and the idea that these are all integrated, especially at the primary care level and universal health coverage level, is essential. And it's not just about TB and radiology for TB. It's about a lot of other conditions that benefit from imaging. And I think probably the most underappreciated imaging modality for which the technology is there is ultrasound. Any obstetric situation, women's health is critically dependent on ultrasound, and it's also useful in many of the NCDs worldwide. And so the fact that it was highlighted as a critical modality, a critical type of diagnostic test, I think now really puts some momentum behind the idea that we ought to be focusing on imaging. I think at a larger level, the rationale is also about breaking down silos. And I imagine that was part of the discussion at the commission, is that laboratory medicine, has been dominant in the field of rolling out diagnostics worldwide, and it's got its own structures and its own approach, and radiology and laboratory medicine aren't very well integrated and connected in thinking through how to apply this. But at the level of patient care and at the level of the patient who needs a test to understand what's going on and what their treatment plan should be, they're integrated. And so I think at FIND, I certainly expect us to work with our partners to take on the challenge of imaging and to focus on modalities that are technically available. The real challenge is in interpretation, and obviously there's basic interpretation that happens at the level of general medical training at clinical officers and nurses and general practitioners and MDs, and then there's specialized interpretation for imaging that's essential for some diseases. And we have to focus on that workforce development and that link to specialized interpretation to understand how to roll out imaging, but that lack of an existing infrastructure shouldn't slow us down from taking it on. So I'm really grateful that the commission highlighted this, and it's essential that we think of this holistically as a set of tools that we need to support high quality care and understand both what conditions are present and how to treat them.
Thanks, Bill. Actually, it's interesting. Our rationale was very much along the lines that you've just mentioned. Clinically, if you're going to investigate a patient presenting with signs and symptoms, you need both, not either. Can I just move? One other question that's come up is actually on value versus affordability. And Sue, as a health economist, the question is, it's all very well having a very expensive test, but it may be the value of that is not good enough, it's not high enough. Do you have any thoughts about this issue of how you judge the value of a test versus the affordability, or how you address or reduce the affordability?
Yeah, great question. Yeah, this is not easy. And I noticed that Fern Terrace-Presshold asked a sort of related question, about the difficulty of doing this. So some diagnostic tests have an incredibly important value. The one test that determines who is a super spreader of COVID is incredibly valuable. But they have to also do many tests of many other people to rule out them having COVID. So it's not easy. And the downstream benefits are also not easy to measure either. The tack that I took in the estimates that I did make for the commission were to try and estimate the value of the treatment costs that were wasted and that the diagnostic tests could prevent that wastage. And then also the value of the productivity of the people whose illness was diagnosed, and thereby avoided mortality and morbidity and financial ruin for their family. But these aren't easy things to do, and clearly more research is needed in this area.
Okay, thanks, Sue. Another question actually I've got actually for the panel, and perhaps Mike, you might pick this up, is workforce. Without an adequately trained workforce, none of this is going to happen. And currently we can't even cope with the demands for trained staff. Could you say a little more about how we're actually going to deal with this huge shortfall of workforce, but at the same time crank up the amount of diagnostics by at least several fold. Is that how best? I know we made some recommendations, but could you say a little bit more of such a key issue?
Yeah, you certainly can. I think one of the key issues about workforce development is that we've had a tendency to try to model what we do globally on what happens in high-income countries. And when one thinks of the time that it takes to train a radiologist or a pathologist or another doctoral scientist, I mean, this is 12, 13, 14 years. And that's just simply too long to scale up workforce capacity in any meaningful way. And so there've been a number of ideas put forth by different groups about ways to shorten training, make it more tailored for the local context. But one interesting idea that's been done a bit in radiology is the concept of giving a very shorter training program that has all the basic essentials. And then as the different imaging modalities become available, then bringing people back for the subspecialty training. That's just one idea. The other thing is to really, for want of a better word, to democratize the use of diagnostics by doing what Bill alluded to earlier, which is to have other people do some of the diagnostic work. Certainly we know, for example, like as Bill said with ultrasound, that a lot of this is already being done by obstetricians and nurse practitioners, nurse midwives, but there are other ways that could also be done. Point of care testing is a good example in the realm of pathology and laboratory medicine. But I think another key thing is going to be the use of technology, particularly as we get more into artificial and augmented intelligence. I mean, one thing to really leverage the existing workforce would be to have artificial augmented intelligence do a lot of the reading and exclude the normal cases, and then limit what a pathologist or radiologist needs to interpret to only those cases that are truly abnormal. Those are just some ideas, but this is an area, I think, Ken, where it's going to take a lot more thought going forward, because what we've been trying in the past, we know at this point simply hasn't worked. We need more innovative ideas.
Amen to that, actually, Mark. Yeah. Another question's come in is about quality. What the Commission's view on how you address quality. Again, there's no point in providing diagnostics of poor quality. Patty, do you have a view about that? Can you answer that question?
Yeah, of course. Actually, there is a section, and I recommend whoever is watching this to really read the Commission report. There is a section that talks about quality and safety. And that's why then in the recommendations, there is a recommendation specifically that talks about the regulatory frameworks and accreditation. So I don't think as a Commission we have all the answers, but this is one issue that needs to be taken into consideration. And we have discussed several options that are based on having a regulatory framework that should be strong enough to avoid things to happen, but also simple enough to allow countries to have the diagnostics that are needed without increasing the prices, which is happening right now in several countries. Thank you.
Thanks, Patty. Another question has come in perhaps for John and Kengason. John, a question coming in about developing manufacturing capacity for diagnostics, etc., in outside of the high-income countries, and people talk about this. When we discussed this with some of the commercial sector during the Commission, their view was that the complexities and difficulties of doing that really just made it very, very difficult and couldn't see it happening in any reasonable time frame. Have you got a response to that or a riposte to that, John?
Ken, maybe while John is coming in, I could say something.
Yeah, please, yeah.
This is about quality assurance and standards. This is very important because I think even more than medicines, in the case of diagnostics, there is a risk of having a lot of substandard diagnostics out there which are not validated, which do not perform well. And that is then, it's a waste of resources and it's also bad for patient outcomes. So most regulatory agencies around the world, I think, have much less capacity in dealing with the quality assurance of diagnostics than they do. They have programs, well-developed programs for medicines and vaccines. And to some extent, this is true for the World Health Organization as well, where the pre-qualification program for medicines and vaccines is far more advanced in terms of the numbers of products that go through it. And the pre-qualification program for diagnostics has been limited to HIV, TB, and malaria. Of course, for medicines also, it started with that, but it's expanded. And with experience with COVID, now we realize, that out of hundreds, in fact, there are thousands of diagnostics out there, but out of a couple of hundred that we've evaluated, several have been rejected. And this has been done, in partnership with FIND, who put together the panels of SERA and who organized at centers around the world a quick evaluation of new diagnostic tests. So I think it's really important also to think about that. And if WHO is going to be expected to do pre-qualification for diagnostics for a broad range of diseases, then it also means that there need to be more resources, because there needs to be manpower, and perhaps we have to think at the global level how this is going to be done, what FIND's role is going to be here, what WHO's role is going to be, how partners can work together. So that's at the global level, which will help countries without capacity, to procure diagnostics, and also helps global agencies like the Global Fund or UNICEF to procure quality assured diagnostics. So I think this is also something that will need, when we talk about financing, some of this financing needs to go into the quality assurance mechanisms.
Okay, thanks, Samia. Bill, I believe you also may have something to say about how you move some of this manufacturing out, or should or shouldn't.
Yeah, just two comments. I appreciate Somia's comments about quality assurance. I think the critical point there is, if we're going to really drive equitable access to testing, we have to make sure they're the right tests that are high quality tests. And that's why the WHO's pre-qual mechanism has been so critical. But if we're going to do this for a broader scope of tests and essential diagnostics, then we need to provide the resources to be able to do that. And the other point I'll make in that is we have to make sure we're not just doing testing for testing's sake. We have to make sure there are clear linkages to either the public health interventions like we've seen in COVID, or to the appropriate therapies. So there's no reason to roll out, say, new testing for screening for hepatitis B and syphilis in pregnant women if we can't actually provide the support that they need to prevent those infections from being transmitted. The issue on manufacturing is a critical one. I think it was John who brought it up earlier in the discussion about how in HIV there's not a single manufacturer on the continent of Africa that can produce end-to-end an HIV test. And that's also been the case since the start of the COVID pandemic for COVID, both molecular testing and RDTs. And the supply chains are expensive and they don't always work. And there's a lot of diversion of supplies to countries that maybe have more money or more access. Like we've certainly seen that on the vaccine side. And it's clearly true in diagnostics as well. And so I think it's going to be essential for us to address the gaps that have been identified by the Commission, and to reach these 47% of the population that have no access or limited access to diagnostics, to make sure they're locally produced and therefore locally available. And so that's an important area of focus from COVID, where there's now efforts that have been successful to support manufacturing in Brazil, in Senegal, in South Africa, and in parts of Asia outside of India, so that those supply chains are shortened, and that countries and citizens and health programs in LMICs have equal access to tests that are affordable and accurate. And I think we're going to see that being a point of emphasis more broadly over the coming years as an outcome both of the Commission's report and the COVID pandemic. And that's, I think, something that we haven't focused on enough in our efforts broadly across our partners.
Thanks, Bill, for that. Just another issue come up. One of the things the Commission's made quite a lot of play of is the setting up something like an alliance to act as a driving force along term advocacy, etc., developing the issues. I've sort of seen this in my own mind as something rather like the Global Fund, perhaps, or Gavi, as that type of group. So, Mia, from your point of view, WHO, is that a reasonable model? Is that the model we should think about? Or do you think diagnostics has something else about it which it doesn't lend itself to that type of approach?
Yeah, again, it's interlinked, and I know Peter's left, otherwise he might have something to say about this. The Global Fund obviously has been a hugely successful mechanism for the procurement of diagnostics and also drugs for those 3 diseases. And UNICEF is the other one. PAHO for the Americas has been the recruitment. So regional procurement mechanisms could be thought of, because you might have diagnostics which are relevant in one region and not in the other. I mean, the Africa AU and the Africa CDC has clearly come together, with a very strong leadership now on the vaccines front, and perhaps the same thing can be done for diagnostics. There's also there's a Defeat NCD partnership that was set up at the global level a few years ago, and I understand that they are looking into the procurement of diagnostics, particularly for hypertension and diabetes, in addition to treatments. So there could be different mechanisms to consider, but where there are already procurement mechanisms in place working well, then maybe we should really first think about, can diagnostics for a broader range of diseases be taken up by some of those entities. And Ken, I think Dr. Vinod Paul has joined now, so you had some questions for him.
Thank you so much.
Dr. Paul, we've missed you. Since you've just joined us, can I maybe just go back maybe a couple of questions and to address to you about the Commission and its impact, actually. The main one I really wanted to touch on was the one that I'd asked other panel members, which is namely about which of the messages and recommendations which were in the report that you thought was the most important, and did you have any views about how best to implement? Did you hear me?
Can you hear me? Yes, I heard you, and I think, am I audible, sir?
Yes, you're audible.
Okay, so what I would do is, in the interest of time, I would thank you so much for the opportunity. I just in one go try to make 3 or 4 important points. I've been doing multitasking or multi-listening. I had a chance to listen to the presentation, so I have a context. But now that I'm taking the mic, I like to make the point, but pardon me if there is any repetition. So firstly, taking India perspective, surely we agree with the core proposition that access to diagnostics is critical for the pursuit of universal health coverage. In our nation, a huge chunk of out-of-pocket expense is related to diagnostic facilities. And I think there is, on top of that, there's a huge unmet need, which is never met with the personal resources. So truly, we endorse, we agree that a journey toward affordable diagnostics for the people is really critical, very, very critical. And I also agree that, yes, this has not found as much attention as it should have till now, but the Lancet Commission, and congratulations for that effort, should help that process taking more center stage. Second point, I like to emphasize that in India, yes, primary healthcare, the last mile is very, very well stated. And in that context, we are refashioning our public primary healthcare system in the nation. By the end of next year, we propose to have our repurposed sub-centers and primary health centers into what we call as health and wellness centers. It's a new look, new agenda, comprehensive primary health care with additional multi-purpose health worker who's a mid-level provider. And in that health and wellness center, there is a clear paradigm for priority diagnostics to be available for all the beneficiaries of that center, the population that it serves. So we are committed to increasing the access to diagnostics in the primary healthcare space. There is a generic list of diagnostics, such as the pregnancy test and the malaria test, and then the list becomes specific if we are in a tribal belt for sickle cell disease, for example. We truly would be very delighted to have strengthening of this effort through discussions and through partnership. The third point I wish to make is India's potential to create and develop and deliver and manufacture affordable diagnostics. And here I'll give an example of how in something like less than 3 months, India and India's industry created, and India's R&D enterprise created 95 diagnostic kits for COVID-19, because this was a call was given by the leadership, and then so many startups and research agencies rose to the occasion. It shows the potential, and I would like that potential to be used for affordable diagnostics in the world. And we look forward to your participation, your guidance, your support, your ideas, and collaboration for us to contribute in that direction. And this will be something that I'll be very pleased to anchor with Dr. Soumya and other colleagues. And we have our Indian Council of Medical Research, which has been anchoring this activity in its own way. I like to remind in that context that our journey for affordable, scalable, accurate diagnostics for anemia is missing still. I think we still are looking for a much more robust, scalable hemoglobin kit even now. I think we're forgetting that is the commonest disease, at least in my nation. Half of the women have anemia, quarter of boys have anemia, and half of children have anemia. In the list of the bars that you showed about the priority diseases, I would urge that we include anemia. And I also want to emphasize that our journey to address anemia, at least in our subcontinent, has been so far more or less unsuccessful. We still have a long way to go. So there may be another wish list to be focused, but yes, indeed, primary care oriented diagnostics would be very useful. My next point is, in very briefly, the place for telemedicine. For high-end diagnostics, like pathology and CT images, for example, telemedicine can be very handy. We would invite you to create such models in the country. We have a footprint of telemedicine well established in our nation. We have the private sector where this kind of a work is being done. So it is not only important to have the diagnostic kits available, but also accurate diagnosis to be made out of the, shall we say, higher end diagnostics that would be placed in higher level facilities when you show that paradigm. So in imaging and in pathology, mastering the telemedicine paradigm and even using AI, for example, would be an endeavor toward which India would be very delighted to our endeavor would be to find workable models for our own nation. We still have to do significant progress in that regard, but we see that as an opportunity. In the end, we endorse the idea of essential diagnostics list. We also believe expansion of diagnostic services across the world, across the nation, is also a job opportunity for health professionals, especially women. And we therefore look upon this as a gain and a win-win situation as we move forward. I'll pause here and apologize for my inability to be fully available, but thank you so much for the opportunity. Thank you indeed.
Thank you very much indeed, Dr. Paul. A very good summary in some ways of highlighting the issues and highlighting also some practical ways to move forward country by country. I think I should probably emphasize that particular point. The Commission recognize that every country is somewhat different and is different to circumstances. And what we tried to do was to lay out a general principles and template that countries perhaps could adopt and modify to reflect their own circumstances. And I think that's really an important point, that at the end of the day, top down will not work. It has to come from within and from bottom up from the companies. But each country will do it perhaps slightly differently, but can learn from each other. I'm conscious now there's actually only 3 or 4 or 5 minutes to go and we should wrap up. I just wanted to thank Dr. Paul and all the colleagues and our panelists and our speakers earlier in the session for their contributions. I just also wanted to add to the thanks that Richard started the session with. He mentioned a lot of the relevant folks, but I just want to add 2 more groups. One is the secretariat we had. We could not have done anything without the 2 graduate students that we had who worked with Professor Sue Horton, Devanshi Shah, and most recently Laura Jimenez. They have been fantastic, and I really personally want to thank them. And I also personally want to thank my deputy chairs, Mike Wilson, and particularly Sue. Sue has been absolutely terrific. Without her, this would not have happened. And she has been an absolute cornerstone. So many thanks indeed, Sue. I'm just going to finish there by saying I first got involved in this about 2007, 2008. And when I started to look into these issues, I have to confess I was somewhat overwhelmed by the size and scale of the problem and thought, how on earth are we ever going to deal with this? But in fact, the reality is we have been making progress. That's the encouraging thing. As been mentioned several times, the WHO's EDL 2018 and beyond. Most recently, both the G7 and the G20 health ministers have recognized that diagnostics is vital. And they've actually, their communiques most recently have actually mentioned diagnostics needs to be improved. So we are making progress. This can be done. And I'd like to think that the Commission could contribute to that dialogue, and in fact, hopefully would be a tipping point in helping countries to plan their own ways of dealing with this diagnostic gap. So on that note, many thanks for all our participants. Many thanks for all the folks who have listened in. There's a slide up there just showing you, if you want to get further information about the Commission and its works, there are a couple of links there and some addresses you can communicate. And thank you. And as President Obama said, we can do this. So despite the size of the problem, we can certainly do this. So thank you and good night.